presentation and discussion comes from the Kentucky Department for Public Health. Lara Daniels will be presenting. Tasha Moses from NAC is going to be backing her up on this because there was a lot, obviously this is a Quitline related question, and there were a lot of data related questions that you may have seen if you looked at the case presentation. So for now, I am going to turn it over to Lara, and we'll get Rich is bringing up the case presentation. Thank you. And Lara, over to you.
Good morning. So I'm Lara Daniels, and I'm the epidemiologist here at the Kentucky Department for Public Health. I also work with our Quitline, Quit Now Kentucky. So the case presentation this morning is going to revolve around referrals to the Quitline, and I really have two main asks for you guys. Number one, how are we going to integrate provider web referrals into Shawnee's workflow? And also, how could we collect referral information for those who decline the provider referral and choose to call in themselves or to enroll online? You could scroll down. And so how the situation has been working, until very recently, Shawnee wasn't using any form of provider referral. The leadership there was a little bit reluctant to adopt the provider referrals because they were concerned about how much time it would take and if it would disrupt their already existing workflow. So what we did was I provided Celine with promotional materials for the clinic, which included brochures, referral cards, and posters for Quit Now Kentucky. And Celine had been encouraging her patients to call Quit Now Kentucky or self-refer on the website. The problem with that is it's difficult to track the success of her efforts because there's no way currently to indicate on the phone or web intake survey whether a patient is referred by Shawnee. So if I'm going to describe the vision of what it would look like if it was working well, I would like for each healthcare provider at Shawnee to encourage patients to consent to a provider referral. That way, Celine could complete the provider referral there at the clinic. However, I understand that some patients will decline a provider referral and they would prefer to call or enroll online instead. And I would like to know whether any caller or self-web refer patient was encouraged to call by Shawnee. And I'm curious to hear opinions on the quality of data gathered from the field that would be added to the intake surveys. And I'm also open to any other suggestions for collecting this information. There have been recent changes in the workflow. I talked to Celine last week or a couple of weeks ago, and she decided to start encouraging provider web referral at her CHC. And although there was a little bit of pushback, again, they're a little bit concerned of how long it's going to take and if it's going to disrupt their workflow. We're working together to find a way to integrate it. So our current idea is to have the provider obtain patient consent so that Celine can complete the provider web referral at a later time. And also, we asked National Jewish Health to add a question to the intake surveys, were you referred by Shawnee Christian Healthcare Center? And this question was added in April, and it's going to roll out on May the 1st. So I'd like to hear opinions on the value of collecting this sort of data to evaluate our efforts. And the data that we have to back up our observations, it's hard to determine the impact of Quit Now Kentucky referrals from Shawnee currently. Calls among Louisville Metro public housing residents have been relatively low since we began this project. We've had about 3 to 5 per month. However, it's difficult to determine how much effect media flight schedules and seasonality are having on these numbers. I'm really expecting and hoping that we're going to see a significant increase in calls starting in April and May in response to the TIPS campaign and Celine and Heath's efforts to promote provider web referral. And I'd like to open it up for questions if anybody can help me on these issues.
That's great, Lara. Thank you so much. Great presentation. Tasha, did you have anything to add before we get some clarifying questions?
No, I think that, can you hear me, Becky?
Yes.
Yeah, no, I think Lara did a great job of, really clarifying what the question was. And we'd be interested in any other CHCs out there, how you've worked with your providers to increase referrals to the Quitline. And if it wasn't, a web referral, or what other mechanisms do you use? I know that some Quitlines, established e-referral, some do fax referral, but what has been the best methods that your community health clinic has used to encourage providers to do those referrals. And more so, I think one of the things that Lara's really interested in, as well as Celine, is this piece about the length of time it takes for the provider to do the referral. I know that clinic time, and I've previously worked at a FQHC, you're limited on time. And so the worry of taking 2 to 3 minutes or even 5 minutes to have to actually make a referral is definitely a concern of the clinic staff. So how has your clinic overcome that burden if you've been able to successfully do it?
Great, thank you. All right, so also I have to apologize before I called on Steve, but I remembered that he is unfortunately not able to join us today. He's traveling, so he and I spoke separately about this. And Laura also gave me some feedback on this before she went out. So, okay, a couple clarifying questions. Number one, how did you originally pull numbers for public housing resident calls?
So I looked at the geography. I looked at all residents that were calling from within the Louisville Metro from Jefferson County. And also, we added the question to the intake back in July, are you a public housing resident? So that's who I decided, that's where I was pulling the numbers from.
Great. And then is the Quitline asking about Shawnee specifically when the patient calls, or if they were referred from a health center? I think that's what you're kind of getting to here, right? You haven't, this is going to be added.
Yeah, it's going to roll out in May, and it was actually, the question is specific to Shawnee. Were you referred by Shawnee Christian Healthcare Center?
Okay, great, thank you. All right, anybody, Linda, did you have anything you wanted to add, or Amy or Frank?
This is Linda. Thanks, Lara, for describing this. And I think, referrals between health centers and Quitlines are an important piece of this project, and we appreciate you really spending some time looking at this. When we set this up, the role of the Quitline was really to assess the number of callers that came from the public housing agency, and the community health centers were going to play a role in assessing the number of referrals that were made to the Quitline. So I did want to just put that on the table, and maybe Becky, you could talk a little bit about where things are with being able to measure that at the community health center level. But I also wanted to suggest, Lara, that the American College of Cardiology put out an expert consensus decision pathway on tobacco cessation treatment in December, actually on Christmas Day 2018. And it's an excellent, excellent document. It's probably 25 pages long, but really an excellent document, I think, for you to take a look at, and also for Shawnee to take a look at in terms of ways that they can be doing tobacco cessation treatment and capturing data at a clinic level. It does go through and talk about a number of the barriers for centers, community health centers, and other clinics to be able to do tobacco cessation treatment. It talks about provider lack of education as a barrier, provider lack of time as a barrier, smoking among healthcare providers as a barrier, and healthcare delivery systems level issues as barrier. And for the provider lack of time, which seemed to be a problem for your partner, utilizing existing resources, including state Quitlines for additional support, is one way to really take the burden off of providers. Having a dedicated smoking cessation counselor or a person responsible at the health center, maybe someone who's not even a provider, to be responsible for sort of looking at who among the patients are smokers is another solution that they offer. And for provider lack of time, those are the two solutions they offer. But I'm happy to send out a link to this. And I think part of this issue is that it's not just the Quitline's responsibility to be measuring the number of smokers, who come through the health center and also what happens to them, that there needs to be a partnership and involvement from the health center side too, to be able to measure who they're referring and what's happening to those patients.
Thank you. And to answer the question about measurement, we'll have, as part of our progress reports and final reports, data from all the CHCs who are participating in this project. So at the end of August, and then the end of the project at the end of March, we'll be able to see from the CHC side how referrals went.
Becky, can I make a quick comment?
Of course.
From the health center side, as you know, health centers are required to report referrals on tobacco cessation or tobacco treatment issues. And so it's something they have to do anyway. And what we're trying to promote with respect to the Quitline is that it is probably the most efficient use of their time. I mean, of all the things that they can do for a patient, the Quitline really gives you maybe the most bang for the buck. I mean, you're talking about 2 or 3 minutes in referral time versus, the full array of services that are provided through the Quitline that the health center, in effect, does not have to expend resources on. So it's really, it's a very efficient use of time, and we're certainly encouraging health centers to use it.
Thank you, Bob.
Sure.
That's great. And Amy or Frank, did you have any additional clarifying questions?
Yeah, just a couple of thoughts here. Number one, I've seen some other health systems. These were hospitals, not health centers, but basically the same thing. Ease into this by actually choosing 1 or 2 or 3 diagnoses that they know are primarily affected by smoking. So let's just pick, everybody who has any kind of pulmonary problem, the system automatically pops up with the question, do you smoke or use any type of tobacco? That way, it seems more relevant to the clinician because it is directly connected to the illness. And you're not having to ask somebody who has a broken toe or a sprain or something that question. Although I think it should be asked for everybody, this might be an easier way to ease into it. So just pick as many diagnoses like heart problems, cancers, etc., that you want, or just start with 1. And number 2, if you have a pharmacist on staff, to echo what Linda just said, they would make an excellent resource to do the cessation counseling right in the clinic. If you can do that. Almost every single pharmacy student in the last 20 years has gotten cessation training in their curriculum. And, and I've trained 50 gazillion pharmacists all over the country who are practicing. So that might be another resource to look at that you hadn't thought about.
Great. Amy?
Yeah, so I agree with all of that. Of course, if we can get the providers to take the time to make those referrals, that's going to be one of the best routes. And they can provide maybe a little bit of that counseling and the treatment with medications. Of course, lack of time and disruption to their current workflow are, real barriers. So as it was mentioned too, if there can be some other staff person, or I think it was mentioned possibly Celine can take on those referrals to the Quitline, to maybe get somebody else involved to take some of that workflow burden off of the providers, and have either some kind of tobacco specialist, or if that's the pharmacist, or even just Celine that's then taking that interested patient and making that referral out to the Quitline. That might help a little bit with some of those barriers. And then of course you'll be able to track a little bit better that that's coming right from Shawnee as well.
Okay, great. Anybody else have any? Oh, we have one more question. Have you communicated to providers about this potential new workflow? And do they do other similar referrals that work well?
Celine has really been my liaison for working with Shawnee, and she has encouraged it with providers, and I just think there's still some initial pushback.
And I can chime in. I was just talking to Lindsay as well, and we're working on the workflow for all of that and considering having our MAs involved in the process. or, you know, figuring out some other way to, as part of the tobacco cessation screening that we already do, maybe putting the web referral as a part of that screening. So that's something that we will work on and figure out a flow for that.
That's good. Celine, are you talking about putting a web referral into the EHR or having the MAs do it?
Having the MAs do the web referral as a part of the screening.
Got it. Got it.
Yeah.
Thank you.
Yeah, and I can, this is Amy again, I can add to that too, just to share some experiences here in Wisconsin. So we have several health systems using electronic referrals built right in. And we did get a lot of pushback, as you can imagine, from providers doing that, spending that extra couple of minutes. So many systems have moved to having the MAs doing that whole process. And it's something that they're used to doing. They might have a little bit more time. It's built right into when they're assessing tobacco use for those patients or clients. And so it seems to fit well, and we've seen higher rates of referrals coming from the MAs as opposed to the providers. So they're doing kind of that workflow, and then it's just left to the providers to either sign off on that or just review that that was put in by those MAs. So we do see that helping the process and kind of releasing some of that burden from the providers.
Thank you. And we have a comment from Catherine at SELC. There are some clinics we have heard of that are experimenting with standing orders. So NRT, pharmacotherapy are all set no matter what. This would mean everything is approved ahead of time. It takes one step out. So Catherine, do you mean approved ahead of the patient visit? Yes, okay. So you have identified at previous appointments that there is a patient who is a smoker, and so when they come in, you're just all set. So there's some background work. Is that kind of what you mean? Okay, great. So she said yes. So that's an interesting idea. Selena, Lindsay, what do you think about that? Do you think that that is something that would be considered for the workflow? Is that even possible to take that extra step and that extra time to identify the smokers ahead of the appointment?
I don't know that we can talk about it with them. I'm not the best person maybe to answer that specifically, but I think that that's definitely something we can discuss and see if that is possible. So I will make a note of that.
Yeah, and I'll of course, you'll of course get this in my notes.
Okay.
Okay.
And this is
all right, great.
Becky, this is Tasha with NAC. We'll be doing some follow-up with Lara and the Kentucky Quitline after the fact, and we'll be happy to connect them with other states that have had a strong track record in referrals in healthcare settings, various healthcare settings, specifically CHCs and FQHCs, because there have been some states that have done this very well. So we'll be sure to connect with her offline to go over that as well.
Thank you, Tasha. And then I wanted to ask from some of the other CHCs on the line, what have you made any QI improvements to this process? What are they, and how have they gone? If anybody wants to talk about that, feel free to come off of mute. No one? No one's made any QI improvements to this process and workflow? Okay.
Becky,
well, yeah.
Well, this is Tasha again. I'll just share some experiences from working with helping various healthcare clinics, hospitals, et cetera, implementing e-referral when we did the project a couple years ago. And I will say that the provider education piece is huge. And one of the reasons, a lot of them that were looking to implement e-referral did receive heavy pushback from providers. And so there was a step before just implementing the workflow that needed to take place. There was a lot of introduction to what they wanted to do, why they wanted to do it. And then there was also to get some buy-in from the physicians as to what would work best for them, what would be helpful to them to make this process go smoother. And so I do understand the eagerness to definitely get right in and get those referrals going. But if there is pushback from the providers, there may be a need to take a step back and maybe get some buy-in from those providers and find out, what their current process is, whether they're referring, how many of them are actually, doing referrals, and then, what, besides time, like what their concern is about making the referrals. If it's just time, maybe solicit some suggestions from them that will work. They may all say, well, if you can get somebody else to do it, we'll definitely be on board with this process. And then it would be up for the clinic to find out what other staff member can take on this role. And then it would just be, making sure that the physician knows that there is another staff member that's going to follow up, but this is your role in the process. So there may need to be some, brown bag lunches where you get the physicians in for them to talk to them and have those conversations with them prior to really enforcing and engaging them in a whole, change in the workflow process. Even if you are getting the MAs involved, I still highly recommend you, talking with the physicians and letting them know about the process and let them feel that they have some buy-in to this prior to just rolling anything out. I think it will help a lot with, in terms of the relationships, as well as in terms of their acceptance of the new workflow.
Thank you, Tasha.
Great, thank you. Thank you. So, Lara and Celine, do you feel like you have some ideas? Did we skip over anything? Because there were two different topics you really wanted to discuss today.
I just wanted to throw out there that the Kentucky Cancer Program is our partner here in Kentucky, and they are excellent for giving provider education workshops on referrals to the Quitline. So it's more than possible that they could schedule a meeting with your providers at Shawnee to just educate everybody about how referral to the Quitline works and the value of it. And I did have one other related question about referrals. Celine has been going to the Public Housing Authority facilities, to their resident council meetings, and giving health education to all of the residents there. And she was wondering if she could give a provider web referral to patients or to people that are at the PHA facilities that are not patients of Shawnee, and if there were any privacy issues with that.
That's a good question. Tasha or Linda may have some insight into, so you're wondering if it's a HIPAA violation for them to make the call? Lara, did I ask that correctly? You wondering if it's a HIPAA? Okay.
That's correct.
So
Okay.
Lara, oh, sorry, this is Tasha. So Lara, I know that the Kentucky, you have that Enroll Now button on the website for tobacco users to self-enroll into the Kentucky's online program and the phone cessation program. Are you talking about that? Are you talking about having someone actually walk with the PHA resident to enroll them into the program, or are you referring to something else? I just need clarity.
I'm referring to the actual provider web referral.
Okay, so you're saying having them actually having a PHA resident go to them, but they would just do it on site. They would collect the information and everything on site.
Exactly.
Yeah, we have some events coming up at the end of May where I'm going to be doing going to the different public housing locations that we're working with. And for those who maybe don't have access to a computer and maybe want a little bit of guidance to fill out the information, there's the sections that ask about the provider information, like the clinic they go to and everything. So I just wanted to clarify that if I'm helping someone to fill that out, but we're not their provider, are there any like HIPAA issues or, yeah. Does that make sense?
That makes sense. And I will defer to someone. I haven't worked in HIPAA in a long time, so I will defer to someone that's more well-versed in that. I'm not sure if anyone else on the line can clarify that. I'd be happy to get you some information offline.
Yeah, I don't think you have a HIPAA issue. You may have an issue where you want to coordinate care with their existing provider if they have one. But from a HIPAA standpoint, I don't really see where there'd be a problem. And I don't know if you have any lawyers on the line, if Cliff is still on the line, or Linda maybe. I don't believe so.
Yeah, this is Linda. I've been thinking about it too, and I also don't see that there's a HIPAA risk here because, you know, Lara and Celine, we could have the public housing agency make a referral as well. And so, you know, in general, there isn't going to be, except with e-referral where medical information does transmit from the healthcare record to the Quitline. For a regular referral, there really isn't healthcare information that's passing through. And we certainly have community organizations that make referrals either using the online button or helping somebody to go to an online site and get themselves referred via the web to the Quitline. So I don't think unless you're transmitting medical information and if it's not a patient, you wouldn't have that. You wouldn't have a HIPAA risk. But we can
Thank you so much.
And
I
what if,
appreciate you clarifying that.
thank you. What if the person being referred doesn't, because I know this may not sound like it makes sense, but what if they don't have the information about their clinic, you know, address or some things like that? Because there's some asterisks on required information for the web referral. And I'm assuming you can't submit the web referral without those specific pieces of information. Is there, but you said there's a way for them to do like a self-referral online to get access. We could give them the internet access and they could do that one instead.
Absolutely, and I would say go with that because the issue Bob raised is really an important one that, you know, when there's a clinical site to Quitline referral, there's an expectation that there can be some coordination of care. And if this person isn't a patient of yours, you wouldn't be able to fulfill that expectation of coordination of care. And so this should come in as a referral, I think, just through the online button that Tasha mentioned, where you could go to the website for the Kentucky Quitline, and there's a button there, or you could go to NAC's website where we have a map, and built into the map, there's a way that you can do an online referral to the Kentucky Quitline. And we can talk with you, Celine, if it would be helpful to get a conference call together for Tasha, Lara, and you just to take a look at that and see how that would work. And it may be that the public housing agency also wants to be on the line for that because they can certainly help people get referred to the Quitline through that online mechanism as well.
Okay, I think I was overlooking the self-referral option. And so that clarifies a lot for me. So thank you for that.